Hey guys, it's about 2:02, so we're going to go ahead and get started. First off, thanks for joining. My name is Gemma Lowry, Program Manager at Christiana Care, and I'll be helping moderate today. Just a few ground rules. If you're here for CME credit, there's a paper you need to sign off on before you leave the session, so make sure you come see me for that. It's 2.5 hours. We know that this is kind of a long time on a Sunday, so we want Karen's going to run through, slides, but we really want this to be interactive. So this isn't something where you have to hold your questions. The room's pretty small, so if you want to raise your hands and answer questions at any point, that's perfectly fine. At the end of each section, we will have a discussion, so we can talk a little bit more about what you've heard. And there is a Q&A section if you're online. Within the app, I'll be checking that to make sure that your questions aren't missed as well, since this is a hybrid session. So without further ado, I am going to introduce Karen Titchener. You guys know at Matrix, we don't read people's bios, so you can definitely find that within the app. But Karen has been in this space for over 20 years on multiple continents and is very, very well versed in the hospital at home space. So looking forward to her discussion, and I'll bring Karen up now and we'll get started. So thanks, guys.
Thanks. If you turn this. Okay, thank you. Thank you very much. I will apologize at the very start for my Irish accent. If you don't understand me, I'm sure Gemma can interpret. But yeah, as Gemma said, I have been working with Hospital at Home for over 20 years. I've set up 7 programs, seen over 15,000 patients. The biggest one was in London, where I employed 85 staff, and we saw 3,500 Hospital at Home patients at any given year. So I got recruited to Utah, which was interesting, and went there for 5 years, and now I'm with a startup company where we help health systems set up Hospital at Home. So I'm not precious about my slides. If we don't get to the end of them, we don't get to the end of them. I'd rather you get the most out of this. And bleed me dry for information. So we will start with just a background of Hospital at Home, and then I was going to talk about establishing a Hospital at Home program, and then just talk a little bit about the Oncology Hospital at Home, which was the US-based Hospital at Home that I established at the University of Utah Huntsman. So please just stick your hand up at any point. And I'd be happy to answer any of your questions. So the big question, what is Hospital at Home? And I don't know, did you want to ask the room first of all?
So as a group here, yes, polling questions, thank you. I didn't put them in, but we'll just do an informal. Who currently has a hospital care program? Who's working on a CMS waiver or thinks they're going to get into the space?
Okay.
Thank you, guys.
Great. And hopefully what I'm telling you is going to be new to you, but who knows? So I'm just going to give you the international evidence. Obviously in non-fee-for-service worlds, it's been going a long time because hospitals in social health systems have capacity issues and they can't just build another hospital. So it's, well, what do we do with what we've got? So, and as the name suggests, it's bringing hospital level care into a person's home. And it's well established in Canada, Japan, Australia, and the United Kingdom. And the model was evolved in order to reduce hospital admissions, but also to get people out early and shift care to a more effective and efficient way in the community. And these programs, internationally, the programs are normally admission avoidance or early discharge. We will talk about the American Hospital at Home in a minute or two. So these programs primarily focused on pneumonia, cellulitis, urinary tract infections, exacerbations of heart failure, COPD. And as I said, they were founded in single payer systems. I actually got out to Australia and New Zealand because they are kind of the earliest documented ones to see their programs. as well as establishing it in the UK. So there are lots of programs out there now that are doing this. The earliest roots in America is really in older people's care. And these programs, they haven't been widely adopted. Obviously, in the last 2 years, there's been a big acceleration of that. But really, it's still small play compared to what it could be and should be, I would suggest. So Kaplan, I actually went to visit him in Sydney. He's a little bit arrogant and didn't really want to talk to me, but but there you go. But he did a meta-analysis and, numbers to treat to show a reduction in mortality was only 50. So that's huge, really. So, reduction in mortality, reduction in readmissions, and showing that it's safe, it's as safe and more effective than a hospital admission. So definitely something to be considered. In the US, as I said, they're primarily have not been adapted well because of your reimbursement. So most of the programs are about geriatric care. And as I said, the programs do show that they are at least comparable to hospitalization, but improve mortality and outcomes. So hospital at home is bringing that. Without hospital at home, these patients would otherwise be in hospital. That's how you have to think of it. So forget home health, forget case management. This is about acute level care. Really, hospital at home doesn't portray the acuity of the patients. These patients are sick. I remember one patient that I went to visit at 11 o'clock in the evening in London. She was a young African family. They had just come into the country. Her husband was working nights. She had no infrastructure. She had 3 young children. She did not want them put into care. And she had acute pyelonephritis. She was not going to stay in hospital because she did not want her kids put in care. So I had to go out and see her. And man, she could hardly get her head off the pillow, but she wasn't going to, have her children looked after by somebody else. So, for me, really, it's where's the safest place, but it's also about, where can that patient be looked after? I know at the minute with the CMS waiver, it's about over 65s. She was only in her 20s, but, in the UK, it's more about decanting the hospitals than the age group that we target. So it is about transferring people to home. It's about substitutive, so they go to the emergency room, but you can extract them out, or else, in some models, which I know it's not in America at the minute, it's like, well, don't even let them go to the emergency room. So, it's really, you really have to look at your health system. How much is it imploding? How much do you want this to succeed in order to help your whole health system? So, my philosophy is never say no, say how. So I never say no to anybody who says, well, have you thought about this patient group or that patient group? So, you just have to think big. So in the USA, interestingly, sort of in the 1930s, a lot of home-based medicine was at 40%. Physicians would go out into patients' homes. But now those numbers have plummeted. In the 1950s, it was 10%. And, 1% of Medicare physicians were visiting in 1993, and it hasn't changed. So 1% of Medicare patients, physician visits, still at 1% today. So, that's a big deal for hospitals that are having problems. And, at the same time, these older people, they represent 21% of people, are homebound that are over 65. They have higher rates of hospitalization, they're vulnerable, they have poor health, and, they haven't got other people that can look after them. So this is the society, people are living longer, they're getting older, and we have to think of a way, how do we look after these people, to keep their quality of life and to keep them as independent as possible for as long as possible. And as I said, there's numerous studies have demonstrated the benefits of home-based medicine in this population. So what's driving this resurgence? Well, the CMS waiver, hospital at home. And an average adult of 65 can expect to have 1 to 3 years of their remaining life needing help with their activities of daily living. And 85% of older people, 85-year-olds is the fastest growing population, increasing by 305% between 2012 and 2050. So, we have to back up and think, what are we going to do with this population and how are we going to look after them in the best way we can? So the high escalating costs, the Medicare can't sustain the increase in volume. So they're going to have to look at new models of care in order to do that. And the associated economic concern has facilitated this new era of, let's not do fee for service, let's do value-based. And hopefully value-based is more about, thinking about the patient rather as well as, how do we do it for the dollars that we have? So many signs are pointing to the future of healthcare shifting to this value-based with a combination of virtual and inpatient. And we know that that's where it's going to go, that we cannot look after this extensive population if we don't now start to think about virtual health and how we look after these patients. It's estimated that US healthcare is going to they're going to shift care to 250 billion towards virtual care in the next coming years. As of October 2021, there were 82 health systems and over 186 hospitals in 33 states that had taken the Medicare waiver. Now, interestingly, only about half of those have actually started a program, because it's not easy to start these programs. It is easy in some ways, but also it's complicated, and people are afraid of losing their Medicare license and things like that if they get it wrong. So there's a little bit of a freak out over it. But, really this should be about decentralizing care and pushing it into the community, where we would hope that people, on one end of the care continuum, people are living well, and then the other end is this acute hospital at home. And in between, you've got the rehab and you've got the short home health bursts that should help. But really the drive should be, let's look after these patients in their home. We know that they'll do better. We know if you take a patient with a UTI and delirium and you stick them in a hospital, they're going to fall and break their hip, and then it's going to take 10 weeks worth of rehab. Whereas you put that care into the home, keep the patient in their own environment where they know how to get a cup of tea and, where their toilet is. It's a very different story. So I really do think that we have to start thinking beyond the walls of the hospital. So Medicare started to look at penalizing hospitals, for their readmissions within 30 days. We know that. So in March 2020, they brought in a thing called Hospital Without Walls program. Now that it's about 24-hour care. So there's not very many places can do it was hospital at home, but it was like, you have to have 24-hour care. So the waiver part of that, which then was brought out in November 20, was that you could look after these patients in their own home, but they didn't need 24-hour care. So, and I'll explain to you what they then decided that they did want within that waiver. So under that program, there's over 60 acute DRGs that you can do, and they will pay you that DRG to take that patient home. So this is how you apply for the waiver. But the background was that it started with the health emergency. So people got COVID, the hospitals were imploding, and they said, goodness, we've got to get these patients out. Excuse the renewal date, this isn't my updated slide, but it renews every 3 months, basically. So at the minute, the current waiver under the public health emergency is going until the end of July. They hope to extend it. At the minute, they're working with policy to try and see if they can bring in an interim policy that will allow it to run for a couple of years before it goes through the the Senate and things like that. So, so they made it a very, very quick turnaround. So like they'll give you a decision within 10 days. If you have seen 25 patients in an acute model at all, then they'll give you the first tier. Otherwise, they'll give you approval, and then you've got some things to do, which I will talk about. Sorry, my clicker's not working. And then this, as I said, you have to have seen more than 25 acute people in their own home. And the second way is that they'll work with you to see your first 25 patients before they give you the waiver. CMS goal is to allow experienced hospitals, to take on this program and see if it works. One of the things that they said was that these patients have to have emergency response. So if they're in their own home and something goes wrong, you may have 24-hour cover in some way, but somebody has to be able to answer the phone and somebody has to be able to go out and see the patient if there is an emergency. So your program really does have to have some kind of 24-hour cover. Other things that they want you to have is, the pharmacy, the infusion, the DME, physical therapy. All of these things you can either partner with a home health or you do yourself. You have to have diagnostics, you have to have transport. Honestly, when I looked at all this, I really feel that they've made it complicated and that this is what freaks people out. I have, as I said, I've developed over 7 hospital at homes. I've never once thought about food or transport because we'll work it out. I've never seen a patient starve. I have given money out of my own pocket to send a nurse to go and buy somebody a meal and cook it for them. So, although they've included all this, people really get, I would say in Ireland, you're knickers and not. I don't know what the American version of that is. But, people get really worked up about it. And it's just like, guys, it's not that complicated. It's food. You don't have to get this big contract with somebody. You can go to your blooming hospital canteen and say, give us a meal to take out to this patient. It's really not, I think, getting into big complicated contracts, I'm not sure if that's really the way you should go with this, but that's just me and my stubborn Irish roots. Yeah, you have to see 25 patients. So the only things that they want you to record, they cannot track these patients on your system. You have to tell them who the patient is. And then that's how, so they can't say, oh, this is a CMS waiver. So at the end of every month, you have to say, did somebody die that you weren't expecting them? What was the escalation rate? And what was the volume of your patients? So it's not a big, that's not a big deal. That's not a big onerous task to report, really. Come on. So the patients have to be either from the emergency room or an inpatient, sadly, and they have to only be Medicare patients, but at least it's a start. So they have to have that. It's either NCO, whatever your coding is in your hospital, they have to have that that coding to say that this is an acute admission, and then that will generate the payment of that DRG. And so then when they're on the program, so they literally have to stick their toe in the emergency room or be admitted, and then you can extrapolate them out. And then after that, they have to have 2 RN visits a day and 1 virtual visit a day or in-person visit a day by a provider. However, if that provider is a nurse practitioner, she cannot go and do the RN visit task and then be the provider. I don't know why, that seems crazy to me, but it is what it is. So you just have to go with the flow. But and the telehealth, the thing is, there are some times that you just have to eyeball the patient, and there's no getting around that. It's just like, I've got to go and listen to their heart or palpate their abdomen. It just is what it is. But most of the time, that telehealth visit from the provider is enough. Honestly, I can say again, in 20 years, I literally could count on one hand, A, the amount of patients who have died unexpectedly, and B, the number that have needed an urgent visit. Because if you've got your staff trained well, and every time they see the patient, I always said to my staff, when you close that door, you have to think, can they pee? Can they get a drink? Are they going to fall? When's the next visit? Because if you are worried about that patient and you think they're not going to be able to get to the toilet, they're not going to be able to eat, then what are we doing leaving them at home on their own? So, you really have to train yourself. And, I can say with no surprise, really, even with working with an outside home health, we really had to coach them into doing that very proactive assessment, because it's not home health. You're not just ticking boxes so you get paid. This is a really sick patient that you have to do a top to toe assessment on, have their bowels open, silly things that they just don't ask. And so, you really have to make sure that all your staff members are coached up to make sure, are you in pain? Can you breathe? Do you look blue around your gills? All of those things. You really have to make sure that the patient is stable enough to look after themselves until your next visit. Now, they say 2 in-person RN visits. If that patient needs 4 RN visits, they need 4 RN visits. In my London program, we had nursing aides, we had physical therapists, we had RNs, we had nurse practitioners. Our patients, we didn't put a limit on the visits. And I would say they're saying this is the minimum requirement, but you have to make that clinical decision as to how much you think that patient. And honestly, for me, on the first day, if that patient only needs 2 visits, are they a hospital at home patient? Are they that sick that you think that you can look after them in 2 visits? So I don't know, I'm just putting it out there. So I really think you have to think of your acuity. And I guess a lot of people who are starting these programs will go with the low hanging fruit. So your COPDs, your heart failures, where their decline is more insidious than somebody, I've just done an oncology program. Well, they're fine in the morning and by the afternoon, they're on their knees. So, very, very different patients to look after. And they talk about transport back to the hospital, that's not the patient or the relative's responsibility. I agree. Again, I could count on one hand the many times I've had to bring a patient back to the hospital. It's, these things that they're making you do, aren't everyday stuff that you end up doing. So, Mount Sinai did this, and this was the DRGs that they did for their patients. And they also stuck on to the end, which I think, and that's something that I want to say from the onset, is hospital at home is just part of the patient's journey. I think it should be, I think it should have, you do your short, sharp 3 to 5 days, and then you maybe do, 30-day bundle post that. And I think that's what they're really trying to do. Because I think those, certainly with the oncology patients that I'll show you later on, doing that acute episode and then managing them 30 days post that acute definitely helped get better results. The CMS waiver, up until October 2021, all of those hospitals had only seen 1,800 patients. That's not going to help any health system if that's the level. So I think people have to really, I'm not undermining it, but I'm saying you can do it, but you can do it bigger and better than that. Really 5 patients, an average daily census of 5 to 10 patients probably isn't going to help your health system with their bed capacity. You have to be looking, well, in the London program that I did, we had 95 patients on at any one time. Now I know we were serving 2 large hospitals that had over 1,000 beds. Those hospitals, their emergency rooms had over 500 patients at any one time. So I know that's a huge health system. So, I'm not expecting you all to have an average daily census of 95, but certainly, 2, 3 a day, people are going to get very bored with that and say, what are we doing? Why are we investing in this? Because that's not going to help our health system. So think that's the end, and I've got references there if you want references. Has anybody got any questions? We'll stop before I move on.
What census would be?
Yeah, honestly, that depends on your health system, and I'm going to go on and explain how you scope your need, and then basically, if you have, I don't know, it depends on like what your bed capacity is. Is your health system saying we have never got any beds, and therefore how many are they expecting you? Honestly, I would say you have to go for at least 10 to have any impact. And even 10 is going to have a tiny impact. So, my target for most organizations, and I'm only just pulling this out of there because it's your organization and you'll know, but I would say anywhere between 10 and 25 is definitely, personally, my motto is go big or go home. So it's either, just go for it. You could easily get 120. If you, laid down just Medicare and you did everything, we did, in the UK, we did over 18s. So we did pyelonephritis, we did hyperemesis, we did renal failure, so I had about 25 clinical pathways. I was telling Gemma early on, we did physically disabled people who and mentally handicapped people who, if they go into hospital, it really upsets their routine and actually they just don't do well. So they reached out to me in London and said, hey, you looked after one of our patients. They did so well because they stayed in their home. How could we do this pathway? So I sat down with them. We wrote a pathway and we did that. So I think, if you're going to impact the health system, I feel that you're going to have to go out of Medicare. So it may be that your health system, and this is just me speaking as somebody who doesn't always know everything, but if your health system really has got that bed capacity, it may be that you do hospital at home as a lost lead so that you get your bed capacity. So you pull out 25, 50 patients, but actually you fill those beds with a more expensive DRG, you get through your waiting lists, people that are waiting for knees, hips, whatever, and things like that. So, I would say you don't put on any limits to what you can do and how you can do it. It's really, I would say with Medicare to get 10 or to get it up to a DRG of 25, you'll be doing pretty good. But I would say, your target should be a minimum of 10. And I don't start with trying to get 10. Don't start with 2 or 3, because, 2 or 3, I think for this program, the message gets out very, very quickly once you start to succeed, and the patients love it. So they're going to tell their physicians, don't ever admit me again. I want to go to that program. We had a little lady in London. She had COPD. She had 13 admissions in the preceding 9 months. The ambulance went out to see her, and she said, "I'm not going there. You have to refer me to that hospital at home." So then the ambulance service then rang me and said, "What's this program that you're doing? Could we do a pathway?" So I went to the London ambulance. Within 2 days, I had a pathway set up, and we took 90 patients from them because they were failing all their targets. Bearing in mind, the UK is it's all the one health system, and nobody's in it for money. You're just in it to provide the service. So it's just different. It's just we all pay our taxes for that, but all I'm saying is it's not a competition. So we're part of the NHS, so we would help the ambulance service. They weren't getting to their patients within 4 minutes, so they were queuing at you don't call it queuing, you call it in a line, whatever. They were lining up to drop their patients off at the hospitals. They could be there. My son's a paramedic. He could be there 2 hours waiting to pass that patient off. Well, in those 2 hours, that ambulance is dead. It's not doing any other work. For their paramedic just to be able to call us and say, hey, this lady's got a UTI or she's got an exacerbation of her COPD, we would triage that over the phone, and then we would go out within 2 hours. That was the pathway was we would see them within 2 hours. And then we kept that patient at home. That then released that ambulance, to go off. So it just makes sense that we all help each other. And the best thing is for that patient in the middle of all that didn't have to sit for 2 hours, at the emergency room before she was admitted. So, I think multiple pathways, multiple ways of doing it is the way to succeed.
Yeah, and I'd say in the States, really a business pro forma is really required. You've got to do the deep dive and see, what your catchment area is, make an assessment, see if you have any value-based contracts, any ACO, anything that makes it, because the US is so much more complicated with payers. I think you have to do that deep dive and do that knowing that your pro forma is your best guess, because you're not going to hit it exactly. But I think that is how you get the buy-in from the business side of this too, is you've got to do that back work.
Any more questions? Yes? Okay. Yes.
So I come from a pediatric health system, so we don't have a lot of CO.
No.
But
good to know.
We do have a lot of mental health cases
Mm-hmm.
issues.
Mm-hmm.
How can we use this for is there anyone using this personally to help with decreasing mental health? And how are they doing it?
Yeah. From my daughter actually is in the UK, you're an adult nurse or a pediatric nurse, and she's a pediatric nurse, and they've actually just started a hospital at home in Southampton. And at the minute they have 10 pathways. I don't think any of those are mental health. There's about 3 programs in the UK that are doing pediatric. I can certainly get you in touch with them and see if any of them. I think there is one of them that is doing mental health pathway, because it's certainly a way. Sorry, this sounds very incestuous, but my niece works in an emergency room, and she for under 18s, and she's a mental health nurse, and she pushes them to programs that will, rather than them being admitted. And also, emergency rooms don't do mental health, as we know very well, at all, and pediatric mental health even worse. So if you have a mental health nurse in the emergency room, that they love that. So I mean, it's not a very nice job, because obviously people are coming in on suicide risk, and they've maybe already attempted suicide. So there are definitely pathways. So I would love you to connect you with some people. It's not my forte. I just know it's there. So I would love to connect you with people that can give you better advice than I probably can.
And it's been exacerbated.
I'm sure it absolutely has been. Yeah.
You
Yes.
may have said this and I might have missed it. I haven't had my
Neither have I, sadly. Otherwise, I wouldn't be standing.
You said, or maybe you didn't. So do the patients have to be monitored 24/7?
No,
They don't.
so that was the hospital without walls. So with the new waiver, that was the part of the waiver was that they didn't need 24-hour care. So they just needed those minimum requirements of the things that I said, two RN and a provider.
And then there has to be a way some sort of way they can signal a EMS or whatever. Is that just calling 911, or how is that?
So again, when they're on the program, they have an escalation. So they have to be told, if you have, obviously, if they need 911, they have to call 911. But if it's just they feel that they're getting more short of breath or their pain's increased.
But the system that's monitoring them will have to have some.
Exactly. Every system would have to. Now, a lot of these hospital at home patients do wear patient monitoring, remote monitoring. Not every hospital at home does that. Certainly the rural program that I set up, we did patient monitoring. In an urban, it may help, it may not. I think remote patient monitoring has its benefits, and it also has its, there's pros and cons of both. But we've certainly in the rural, it's been invaluable. And so these programs do have that. And obviously that has its own escalation. So, and you can set it per patient. So if their heart rate goes over this, if, you know, we had one where it told you if they fell and it alarmed, so then you could call them straight away. So I think patient monitoring is definitely the way forward. I think it probably has to get a bit smarter, you know, it has to be able to do things, because at the minute, like if for blood pressure and pulse oximetry, they have to put that on and they have to record it. Whereas, and I know, you know, I'm not a technical person at all. So, but I'm just saying, I think it's growing, but it probably needs to get a bit smarter before it would be used for very, very acute patients, especially the pulse oximetry. I mean, they can wear it, but they then have to record it and things. So it's a little bit more difficult. But yeah, that was the part of the waiver, was that it wasn't 24/7 care.
No, and now I am a little more techie, so I'll chime in for that one. Is that we do send out a tech kit to
Yeah.
the home,
Yeah.
so that there is connectivity. Because if these are acute inpatient status to qualify, they have to have the comparison of a call bell.
Yeah.
So there has to be. So they wear
Yeah.
PERS, so they have something on them all the time. They also
Yeah.
have a tablet that lets them call the
Yeah.
command center. Also, you've got those 2 in-person visits during the day.
Mm.
So their vitals are being taken,
Yeah.
during that time. It's being
They have to be
uploaded into
taken,
their
yeah.
information. So you have that full picture.
Yeah.
And then they have all the service providers that are coming in addition to those visits.
Yeah.
So somebody may be doing labs, pharmacy may be dropping off. So you've got lots of touch points. So they don't completely avoid all the, visits you get in the hospital with everybody bugging you. You still have that happening,
Yeah.
but there is very much a tech component, because that telehealth requirement, you can do a
Yeah.
video visit for one of those visits, but you have to have that all set
Yeah.
up, and it's not the patient's responsibility
No.
at all. So it's got redundancies, backup power, all of those
Yeah.
things to make it function.
Yeah. But every system is different as to what they do with that, but everybody will have a tablet of some kind. Yes. I tend to do that. They do. They have to have a means of a visit. Most, at the minute, the technology is out there that most people can be given a tablet of some kind that they can, just push a button and they can get the command center. Because most of these hospital homes have a command center, They have to be they have to have 24. There has to be somebody, like I said earlier, there has to be somebody that can respond to that patient's push. So they have to have somebody that can answer a call 24/7. Otherwise, it's not a hospital at home program.
Yeah, it's not 24-hour monitor.
No.
They're not wearing, they don't, right, but they have to have access to somebody 24 hours a day.
They do. And with the built-in thing that if they need a visit, they have to get a visit. Now, some people outsource that to 911, so they would have an acute response ambulance. And at the end of the day, these paramedics have got more kit than we can have. They have got control drugs. They've got things that we aren't allowed to carry. So I think they're a great first response to your patient.
Okay. So then the patient has to collect data through our system twice a day.
No.
They don't
The
collect
nurse
it.
has
the
to-
nurse that comes to the house.
No, it
Well,
isn't. No.
That's the thing. You'll have some people that put a patch on and
Yeah.
it does it for them. And
Yes.
you'll have other practices where the nurse goes out and puts it into the tablet. So you can do it both ways.
Yeah.
Yes.
Yes, but you have to record. You have to. The nurse that does those 2 visits has to document their clinical observations, their heart rate. So whether you're monitoring them, you're doing remote patient monitoring or not, when the nurse does that visit, those have to be documented somewhere.
In person or-
Yes, it has to be 2 in-person visits, 2 in-person clinical observations done. Vitals, sorry, you call them. Yep. Mm-hmm. Yep.
So if the patient gets up in the morning and say, and there's something else, and call that patient to an assessment patient, realize that someone needs to come in the home.
Mm-hmm,
So that can kind of be the springboard
mm-hmm.
for when nurses need to visit or if the speech therapist needs to visit. I know nurses have to take flight today,
Mm.
but it may springboard and visit.
It could, absolutely.
Because to me, what's boggling in my mind is how am I going to determine what time of day I'm going to send nurse back
Yeah.
to see the patient? If
Yeah.
I had data in the beginning of the day that can drive that
Well,
decision.
the remote patient monitoring that we did, our nurses had an app on their phone so they could see everybody on that.
Right.
And so that they started their day with that, you know, and that would escalate a visit, as you said, because they had, and the nice thing about that is it's individualized to the patient, because I might tick away quite happily with a heart rate of 100, but if Mrs. Jones got 100, you were thinking, you know, I need to get out there quick. So it's very individualized with your remote patient monitoring, and you can individualize it to that patient. You want to trigger if their respiratory rate drops to this, their heart rate drops to this. And, you know, we actually picked up, we had 2 escalations with the remote patient monitoring. One was that the patient actually had a PE, and the other, they went into heart block. So, you know, we picked those up straight away, got them into, you know, those patients, you know, don't be sending them out for a visit. They've got they have to go in. So, you know, because hospital at home is never about denying somebody of an appropriate admission or emergency room. It's about how you manage their, you know, their chronic condition in their home.
You mentioned the minimum requirement. What is the minimum requirement for the physician or mid-level provider?
Once a day, remote or in person. And the general feeling of these programs is it's between 3 and 5 days. So that's the minimum physician requirement.
There was a question, sorry, just for the online
Okay.
folks. There was a question from somebody who asked, what was the malpractice percentage? Did we have any numbers yet on malpractice occurring within this space yet?
So I haven't heard any in America. I've been doing it 20 years, and I'm part of the Worldwide Congress on Hospital at Home. I've never heard of any malpractice. I know, you know, America is a more litigious society, so it may be that it happens with this. But the difference here is in the UK and in social health system, really the patient doesn't get a choice. It's like you are going home. It's not, do you want to go home? Whereas with in your health system, it seems that you have to ask the patient if that's what they want to do, kind of thing. You know, and that's, I don't mean to be unkind about, you know, us telling the patient that they have to go. It's just like 99% of the patients think, hell yes, I want to go home, rather than, you know, go into hospital. Any other questions?
Can you guys, does this work at all? Can you guys hear me here? It's, yeah, those online can't. So I was curious. There was a rather long question, but this one is that the waivers in the United States are not permanent. We know that they're kind of being extended by 90-day increments. So what do we think? What do you think is going to happen if reimbursement isn't made permanent? Will everyone need to move strictly to fee for value?
I think it will come, but if it doesn't come, I think there's already enough evidence there. I mean, the world's been doing it for 20 years. So I think there's enough evidence there for health systems to think this is the way ahead. I don't need to build another 500, you know, bedded hospital. We need to try and push more care out into the community, because I think, you know, people are living longer, and you know, your hospitals aren't going to be able to sustain this. So I think the way forward is you may not get reimbursed for it, but you will still, it'll still help the whole system flow better. Okay, let's get on to the next thing then. Anybody need a rest break first? Are you all okay? There's one more section. Okay. This is not going to work now. Okay. Uh-oh, why won't this work? Did you do something? Oh, there we go. I'm going to have to click it. Okay, so here we go. And I'm trying not to insult anybody, but hospital at home. I've been doing community nursing, acute community nursing for 20 years. So what I say about hospital at home is it's not hot chocolate and slippers. It's not rock steady Eddie. Please don't ever call it home health, because it's not home health. Home health has its place and it's really essential service, but hospital at home, it's nothing to do with home health. Home health are there to refer the patient on to after yours. So it's not post-acute care. It really shouldn't just be about the old crinklies. It should be, sorry, that's, I'm getting there myself. I'm getting there myself. So, and it's not home health, and it's also not chronic disease management. All of these things are an adjunct to it, but not part of it. So, these patients, they have an acute illness that needs managed. It's an exacerbation of a chronic condition. As I say, they should be in hospital. They need the expertise. So even when you're recruiting into this program, you have to think about it's not for the faint-hearted. I remember in my London program, I recruited, these high-flying nurses that were in the emergency room. They nearly pooed their pants when they come out to see these patients, because they didn't have a physician 10 yards away to say, sorry, am I being a bit bad with my language? Sorry. But, it freaked them out, because they were used to having a physician 10 yards away that they could go and run and say, hey, can you come and see Mrs. Jones? So they really had to change their mindset and get used to looking after a very sick patient in the home. So, when you're recruiting to this, as I say, it's not for the faint-hearted. It is admission prevention. Although it's not here at the minute, but it will be at some point. Somebody will wake up and say, well, why are we waiting for these patients? A little bit like you said, the patient remote monitoring escalates this patient. It's just like, well, why are we sending them to emergency room? We can go straight out. So, yeah, exactly. It will come. I suspect you're probably about 10 years off that, but we'll get there. So what is it? High acuity, complex patients, differentiates them. That acuity and complexity differentiates them from a home health need. It provides urgent access to diagnostics. Our program, they had EKGs, they had bladder scans, they had pulse oximeters, they had beside the patient lab testing. So, it's all of those things that you're not going to get outside the scope of hospital at home. The patient requires daily input from a multidisciplinary team. As I said, my program in London, we had occupational therapists, physical therapists, pharmacists, social workers, nurses, nursing aides, and doctors as well. So, whatever that patient needs, they should be able to get in the home. You should have, I'm a great advocate of this. I'm a director of the UK Hospital at Home Society. They don't all agree with this, but I think if you're a hospital at home, you should have 24-hour access to somebody. That's just my personal view. Just because of the integrity of the patient. It's just like if that patient's, if they're sick enough to be in a hospital at home program, they really must have an escalation process. Again, I would say very, very few do ever, but it's always good to have that option. And it requires that acute level specialty leadership with clear lines of clinical responsibility. So in the UK, our program took on the clinical responsibility. So if the hospital physician referred the patient or the community GP referred the patient, we took clinical responsibility while they were on the program. That probably difference between programs here. It could be that the hospitalist takes clinical responsibility. Of course, in the CMS waiver, the hospital does have to take clinical responsibility. And then I think you do need defined inclusion exclusion criteria. Although I never say no to patients, I think it's really important that you understand boundaries. So for example, if a patient has drug problems or severe mental health problems that they can't engage with the acute episode of care, you have to be mindful of your staff and be mindful of the patient. So, again, I would say hospital at home isn't for everybody. So you have to just think about your patient group. And the program should deliver care within 3 to 5 days. Come on now, don't mess me about. So for me, what are the key organization things that you want to think about when you're building a program? What's the design and model based on? So build your business case. What a little bit like you were saying, what's your gaps? What gaps do you want to fill? There's no point in building a program if you're a perfect health system and you have no gaps. So, which I haven't found one out there yet, but so that's, you really need to, and for me, that takes a lot of investigating. I never start a program until about 6 months in, because I spend the time, I do chart reviews, I do clinical reference groups, I speak to all the physicians, I speak to all the managers of the emergency rooms. What are the things that are making, that are worrying you, keeping you awake at night, and how can we fill those gaps? So that business case to me is the key, because also then you can say in a year's time, hey, look what we've done. You've like one of the oncologist nurses said, we love your program because now we can get our chemotherapy patients in on the day we want them in. We don't have to wait for 5 days. So there's your evidence that your program is already helping to, decant the hospital so you can get the patients in that you need to get in. Is that a word you use, decant? Is that okay? Okay. You can interpret. And again, for me, one of your key successes is you've got to get that strategic engagement. So who are you going to talk to in order to make your program succeed? For me, again, that was 6 months of walking the floors, spending time in the emergency room, going on the ward rounds, my program in London served 19 GP, different practices. I went around to every one of them to talk about the patients and talk about the program. So really that engagement to me was why the program, one of the reasons the program succeeded, because people got buy-in. And also I think part of that buy-in is if you let them feel that they're part of the design, so that you're not just bringing them and say, hey, look at this wonderful program we've designed, but rather say to them, well, what patients do you think we should take? How could we do this? And then I think if they feel that they're listened to and that they've got a buy-in, it's so much easier to then walk the walk with them, because they'll want to succeed because they've heard you and they've listened to you. And then, developing the clinical pathways is a big part of it. Who's going to work, what group are you going to go for first? Is it your COPDs and heart failure? Anything else? Oh, I'm back. And then, documenting your systems and your processes and your logistics. Who's going to do what visits? Are you going to do a daily huddle? Who's going to report back on the patients? All of that. When you've got 95 patients, that's pretty stressful, and you've got to get that down. Because somebody's got to be monitoring all of those patients and thinking when their labs comes in, I need to look at those labs and things. So really, getting those processes and systems are really important. And part of that is your technology. So part of that is where you have that interoperability of your health records and of being able to talk to each other when you're out in the field, having HIPAA compliant apps on your phone that you can just text somebody and say, hey, she needs this medication or that medication. Now, I always say never use the app if somebody's got a heart rate of 140 and a rest rate of 40. If you put it on a text, you lose your job, because that person is sick and the app's not for an emergency. So, because I had one nurse who said, "Oh yeah, I couldn't rise the patient." It's just like, well, you felt you would put that on the app, and they're like, what? But anyway, so I think your technology, technology for the virtual visits, technology for the remote patient monitoring, and much, much more. I would love to see a one system does all, where everybody can just turn on an app and all of the information is there with the patient. We're not there, but hopefully we'll get there. And as I sort of hinted to before, it's the team, it's the skill mix, it's the education and building your team. Your education for nurses is different. Here in the UK, I was able to work with with King's College London, and our nurses could go on advanced physical assessment courses and things like that. They could, that they were able to raise the standards. I also sent physical therapists and pharmacists because I thought, I'm not sending another person out there. If you're going out there, you can listen to their chest, even if you're a pharmacist. So we kind of diverse those skill sets. Because in London, it could take you an hour to find a parking space to visit somebody. So something else that I did was, I was thinking, gosh, because I needed everybody to do at least 8 visits a day. To have 95 patients on the program, they had to work their butts off to see 8 patients a day. And if they were spending an hour finding a parking space, it just wasn't going to work. So I thought, I know what I'll do. I'll get a driver, because we have a system in the UK called out of hours. So when the GPs go home and put their feet up at 6 o'clock, another service takes over from 6 o'clock to 6 o'clock, and they have drivers. So I thought, well, you're not driving during the day. Then you're not driving during the day. So hey, could you take our staff out? So they would come to our office at 8 in the morning. They would take 4 staff. They would drop them all off. Whoever was finished first would call. And it just made us far more efficient and effective. So, I think with these programs, that's why I don't like to put anything in a box, because everything goes. You just have to, I don't know if that's me or is it, shall I put it down? And so these to me are, and I'll talk in a minute about the enablers, but, what gaps do you want to fill? What are the pressures? What are the quick wins? Are you going to finance the program, or are you hoping that the DRG and reimbursement does it all? I don't think it will, but it's worth a go. And what are you wanting this to do? What are the key performance indicators? What outcomes do you want to measure? And are you going to be a rapid response admission avoidance, CMS waiver? What are you going to do? So for me, the things that I like to measure are your length of stay on the program, escalations to the emergency room, escalations that led to a hospital admission, and readmissions within 30 days, emergency room admissions, and the development of pressure injuries. CMS, as I said, want you to report unanticipated mortality, escalation rate, transferring back to the hospital, and the volume of patients treated. So these things, I just think the more, the day you start, you want to be producing data. Because in a year's time, when they say, well, we've no budget for this next year, you can say, yes, but look at our evidence. We reduced this, we reduced that. So for me, get somebody who's a researcher to sit alongside you and get that, get that control group going against the patients that are in your program. So when you're designing, as I said, budget, target, what patients are you wanting to do? Are you just wanting to do the CMS waiver? Are you thinking, beyond the CMS waiver? At least CMS have started other payers thinking. So I'm hoping that, not too long before the other payers start to wake up and think, what are you purely wanting nurses and doctors on the team, or do you think you need other people? Obviously, you need administrators, and you need administrators with brains to do this as well, because it's not for the faint-hearted. So you do need intelligent people who are going to be able to help you with your logistics. And where's your team going to be located? Out in the community or in the hospital? I would say if you're not, I feel like a little Rottweiler, when I'm trying to recruit patients, it's just like nipping in everybody's heels. I'm just there all of the time. I'm in the emergency room. I'm at the discharge planning meetings. I'm at the clinic saying, well, why are you admitting that patient? We could take them, and things like that. So, and get your inclusion exclusion criteria out there. You know, I've talked a bit about this, so I'm not going to reword it, but just get those strategic people involved in your service design. We called it in the UK clinical engagement, and you know, we had the pharmacists there, we had the microbiologists there, we had the geriatricians there, we had people around the table that, you know, and some people will be more for this than against it, you know, and others will be more against it than for it. So you'll always have those diverse people in the room, you know, especially if you get compliance in there or legal in there, because this kind of freaks them out a bit. And so I know it's safe, you know it's safe. It's just trying to make sure that it's safe within the system, really. And as I say, you're scoping the gaps through observation, through going to the wards and the clinics, out into the community, and just feel a part. I think you'll get more buy-in if you're a part of the system and you're not Billy No Mates in the corner. You're like, you're with people, you're part of the health system. You're not a standalone program. I'm a silo and look at me, aren't I wonderful? It's like, well, how can I be part of the system? Because then you'll get far better buy-in that way. So just talk to everybody. Present. That's all I did. That's all I did before the program, and I continue to do it after. You know, your C-suite, your physicians, your nurse managers. It goes on and on and on. But I love doing that because you can see I can talk. So you just keep talking to these people, and they will love it. In the end, they'll get there. So, you know, build confidence in the program. Think about what your low-hanging fruit is. What are the quick wins that we can do to get the buy-in? And then when you get those quick wins, you know, good news spreads very quickly if your program is doing well. Mine spread too quickly because we got inundated with lots of people wanting to get on board with it. But you know, that we never said no to any patient. I always, you know, if I was off for a day and they had turned down a patient, I wanted to know why the next day. Because it's just like, you know, I know you didn't have capacity, but we still needed to do it. Because, you know, I never wanted, because I feel like doctors are a bit like elephants, they never forget. So if you turn down one of their patients, they'll be reluctant to refer again. So you want to keep your physicians on side, get them to buy into the program, because I think if you get early adopters, they will make other people adopt the program. So we had leaflets, we had posters, we have, you know, I stuck up because we only did 20-mile radius, for example. So I had posters with zip codes, you know, so that it was easy for people, because you just want to make it as easy as possible. People will automatically go in the route of least resistance, which we all know is just sticking the patient in a hospital bed. So if you can make the process where they can think just a little bit outside that box, then you just have to try and help people. You know, develop your clinical pathways. I think these are really important. You know, select your DRGs, what you want to do. And within those DRGs, then, you know, talk to your cardiologists, talk to your pulmonologists, talk to your infectious diseases and those kind of people, because, and get them engaged in, you know, what patients do you want us to take? What patients will we say no to? So that you then have clear reference to say, this patient is for the program, this patient isn't. So, and for me, they're the experts. So, you know, whenever I had anybody, you know, the renal physician said to me in London, well, you look after these heart failure patients really well. You know, our renal patients, you know, when they're waiting for a transplant, they need offloading. And I said, well, you write the pathway and we'll take them, because he's the expert. I don't want to talk about a GFR on a renal patient as opposed to a heart failure patient. So I think, you know, engage your experts and they will buy in. And you have to also think with hospital at home, palliative and end of life. You know, when do you decide that flogging the horse is done with? And you just have to allow this patient to have quality of life. So, you know, think early on, because there will be patients that will be revolving doors to hospital at home instead of the hospital per se. So, you know, you have to have staff that can have those goals of care, end of life conversations with these patients. Again, just to give them quality and dignity, you know, at that end part of their life. I had one lovely little patient who was a sea captain, and the only thing he wanted to do every day was to go to the pub for his lunch. And he had really bad heart failure. So to his dying day, our team gave him intravenous, you know, diuretics, and so that he could go to the pub for his lunch. We didn't even measure his renal function in the end, because it's just like, he can breathe, he can get to the pub for his lunch. We know he's dying, his heart's not going to get any better. You know, and we had that discussion with him. So, you know, I think even though this is a fast flow service, you have to think of the whole care continuum for the patient, and in a just a compassionate and loving way, because these patients are the sweetest people out. You know, your documentation, your policies, procedures, referral process, just get that all, you know, on flow charts so that everybody knows exactly what they're doing and what the process is. In an ideal world, this would be on a tech platform that you just push the button and it sent the patient through, that you know exactly, oh, right, I see Mrs. Jones has been discharged, she's got her, you know, so it would be lovely if we could do all of this not manually like we have to do at the minute. So yeah, you know, with your technology, you know, you have to look at, you know, Epic. Most people are on Epic, you know, the virtual unit there, getting your hospital at home program on that. I think all programs need a command center, not just a technical command center, but, you know, I kind of call it, you know, my kids always listen to Thomas the Tank Engine, so I kind of call it the fat controller, you know, somebody that's there and knows everything about everybody and is directing staff, directing patients. So for me, it's really, really important that you have that command center and that you have that technology overnight, that the patient can always reach somebody if they need it. There should never be a time. That's why, and again, with my programs, no patient ever speaks to an answer phone. If a patient's calling you, they need to speak to you, and they don't give them press 1 for this and press 2 for this. Just have somebody on the end of a voice that they can speak to and reassure them to get that patient out there. You know, remote monitoring, getting that on board, getting the patients. I have to say, most patients are very compliant with this. They don't mind it at all. I'm not sure I would want a sticker on my chest, but there you go. They seem to enjoy, they seem to just, they suck it up, because I think they know that it's part of what the care is. And as I said, the triage, the notifications, the emergency response, that all needs to be built in to your tech platform, and the home-based care. Now, I know at the minute, a lot of, you know, when I talk to a lot of programs, if they're outsourcing their home health, for the CMS waiver, they have to do a bit of tedious task like cutting and pasting the nurse's assessment and putting it into Epic, because if CMS ever audit you and you haven't documented, they'll say, well, how can you prove to me the patient had the visits? So I think that's really important. Although, as I say, much better if we all just had the same records. So your team, good leadership, medical director, hospitalist, nurse practitioners, emergency care practitioner, you know, emergency medicine, paramedics, care assistants. You know, the SAS in England say, recruit the best to be the best. And that's what I say. I turn down more people than I employ, because for me, you just have to get the right mindset and the right person. It's not hot chocolate and slippers, it's Red Bull and steroids. It's like you're on the go all the time. You're like, it's, you know, it is a sprint, it's not a marathon. So if you can't be heading to Mrs. Jones and then you get a call and you have to go to Mr. Black that way, if you can't live with that in your head, it's not for you. So, you know, really, really, really think about your staff. Minimum induction of a month. You want to get them, you know, I do a whole presentation on the philosophy of care in hospital at home. You know, you just have to get them it in their DNA and them to understand, their competencies, mentorship for the RNs, to coach them along. I would love to see student nurses and junior doctors in these programs. They are in my London program, we had student nurses and junior doctors and things. So, because you have to think about sustainability and growth. No, at the minute, no doctor would think, oh, I'll go to med school and be a hospital at home doctor, because they don't really know about it. But rest assured, if they spent some time in this program, and the same as nurses, they may well think, gosh, this would be an amazing thing to do. Your leadership of these programs, they have to be visionary, pioneering, innovative, ability to be flexible. I always said to my staff, I would never ask them to do anything I wouldn't roll my sleeves up and do myself. So, we had a patient with that the oncology clinic said, we're really worried about this person. He didn't turn up to his appointment. Could you send one of your nurse practitioners out? This man was from Guyana. He didn't speak English. He had a 13-year-old daughter. She was the only one in the family who spoke English. So our nurse practitioner thought, right, we'll get out there for 3 o'clock, because that's when the daughter comes home from school. She got in to see the patient. He was lying on the floor in his own excrement. He'd been lying there for 3 days in the fetal position, his daughter said. Because you have to remember, different cultures, that was probably, they all had to get out and earn their money and go to school. But he was roaring in pain. And, that within 2 hours, we had just whipped up all the troops. He had a hospital bed. He had a PC, he had a pump put in. He was washed and dressed and, put in his bed. And it's just like, that's what you would do. I don't care what any state any patient is in. I'll do my best to give them dignity and to sort them out. So I think if you, as a leader, if you have that philosophy, you then spread that out to your staff, so that they really put the needs of the patient before anything else, and please, before money. So for me, the enablers to success: a dedicated team to develop it, operational leadership, get your business case, get your sustainability built in there, regularly meet with your stakeholders. Who are those people that you just have to keep nibbling in their ear, on and on and on and on, but you just have to keep them going, because you want this to keep going. Integrated IT, telecommunications, fit for purpose for this. Scale up your model, clear patient pathways. The single point access, I think, is really important. One number for everybody to talk to you. Don't give people 5 numbers. They want to talk to a nurse, same number. Patient wants to talk, same number. Don't have lots of numbers. One number to do everything. That's what I kind of feel. And a physical presence. As I said, just get your staff out there. If you can't recruit patients, get them sitting in the discharge meetings, get them sitting in the emergency room. Try not to upset too many people, but just get them out there, get case finders, involve the patients with feedback. The patients love this. So they're going to tell their physician, I want that program again. They were great. They did this. Because the whole point about hospital at home is that they're not just looking after your acute heart failure. They're looking at, what's your functionality around the home? Have you got food in the fridge? Is there, a carcass of a chicken with flies all over it, which means that you're not looking after your well-being and things like that. So it's not just about looking after the acute presentation. It's about the whole picture of that patient and how they're going to stay as well as possible for as long as possible. Get your staff trained to be the best, confident with the patient, integrated multidisciplinary team, consistent service presence. Something that we did in London, and we also managed to do it here, although not as easily because it's a different system, was that our nurses and doctors, our nurse practitioner and doctors carried the drugs that they needed for an urgent, because there's no point, if you're going out to see somebody and they're roaring in pain and it takes you 4 hours to get that medicine from the pharmacy, it's no good. You've got to send them to the emergency room. So all of our staff carry a first dose kit. Whether it is that they're constipated and they need something, again, they want it straight away because they're, or they need offloading, or they need an IV antibiotic, or they need an oral antibiotic. We have like 2 or 3 of each medicine in this bag that they can just give to the patient. And then here what we do is we put their MRN number, we bring the kit back, it gets redone every time. So we've got about 13 of them so that there's always one on the go. Because the minute you take something out, you don't want somebody else to take that out because you don't have an antiemetic or pain relief with it. So I think, and you know, we try to have this, but like a ready-made equipment kit. Because again, if somebody needs a walking frame or a commode or oxygen, you don't want to wait for hours for that to be delivered. They need it and they need it now. So try and have sort of that ready-made store or a nebulizer or something like that. So key pointers, good leadership, recruit the best to be the best, in-depth training, daily operations, seamless patient flow, good communication, and never say no, say how, and think big. So I think we should have a break now, or do you want some questions first?
Up to you guys. Take a 2-minute break. Come back. Break.
Sure.
See you guys in 10.
Yeah, you probably answered. I'm just going to repeat the question because the people online don't hear your question. So one was, is there a set model really to staffing, and do these staff then are they only dedicated to hospital at home, or do they integrate into other? And if it's only for hospital at home, then is there an upfront cost? So I would say that you can choose your model. Some health systems, I mean, you can probably hear I'm a control freak, so I really want everybody under my wings. I want to be able to know what the staff are doing and what their skill set is. So to outsource that to somebody else, I was very worried. We had to do that with this oncology hospital at home, which is why I brought their staff in and trained them, and they give us 10 dedicated RNs that only did our oncology hospital at home. And even though they were part of the home health, they only looked after these oncology patients. Certainly with recruiting staff, there will be that. If you have to look at like how many patients, therefore how many staff. So how many providers. Honestly, my programs have all been about 95% nurse practitioners. A physician, like in the oncology, we had a medical director, but they didn't see patients. They were just there to walk us through the processes and things like that. So I've left my water over there. Sorry, I'm getting dry. So I would say thank you. I would say your model is really correlate to how many patients you're hoping to take. And so therefore, I would say there is that initial recruitment phase that you need. And that's really part of that 6 months before you go live, where you're getting everybody on board and you're recruiting your staff and you're educating your staff and you're selling the program and things like that. So definitely an upfront cost. These guys, their bottoms won't ever sit in a seat because they'll be flying around like flies, because it's busy. It's not a program where you're sitting thinking, oh, what am I going to do for the next 2 hours? And if they're not busy, they should be in the emergency room or the hospital's trying to get patients out. So these guys will not have time or capacity to do anything else. I would say, around your medical leadership, it may be that a hospitalist is involved from the hospital, but again, they won't necessarily go out and see the patients. They might just help you oversee the clinicians on the program. But, my background is a nurse practitioner. So I know nurse practitioners can do that and we can have some medical input, but doctors are, way more expensive. And, if it can be done by a nurse practitioner and overseen by a doctor, then why not?
Yeah, and I guess we were a little bit different because we, the upfront cost is real and you don't know what your volume is going to be right away. So we tried to straddle the fence of part-time. That's an epic failure. It does not work very well at all, because when you never know when you're going to get a patient. And if that's not part of somebody's part-time with you, you're stuck, everybody's scrambling. So we backed away from that because there's just you can't predict when a patient's going to pop up. So you can't do that. We learned very quickly, no. We do have a hospitalist that partners with us. They do not ever go see the patient. They are for a virtual consult. So there's always somebody available for a consult.
Yeah.
If the APC or a nurse or somebody's in the field. We have a mix of what we call patient digital ambassadors. So somebody's got to do all this logistics and navigating and sending people out to the home, and shouldn't be a nurse. So we have folks that handle kind of the service appointments that have to have, who's setting up the lab appointment, who's setting up PT or OT to come out to the house. They manage all of that. Then we have virtual nurses that sit in the command center and are available for those, calls from the patient or from somebody in the home, because they also have to, you're taking a patient out of an acute setting in a hospital. So they don't get to take meds without somebody checking in. Like we're on video, we're looking, we're seeing what they're doing, observing a visit with that's someone else in the home, so that we have at the end of the day, our name's on this visit. So we want to know what everybody's doing. So there's people whose butts are in the seat in the command center, but then to Karen's point, the advanced practice providers, the other folks, they're all in doing rounds in the ED, up on the floors, recruiting and looking for patients, and sometimes just answering questions. It's still new. So everybody we got to get them out of the habit of saying, please explain to me how an acute patient can go to home health. We're like, it's not home health. So it's acute hospital care at home. And you just have to keep reiterating that and reiterating it. Go ahead.
Yeah, with that in mind, just curious, in terms of ramping up utilization early, do you see more of the kind of push strategy or pull strategy, right? Bringing in the right patients?
It's hard. I'll take that one, Karen, just real quick. It's hard because there's still people, no matter how much, and Karen's model is beautiful with the 6-month kind of work up to going live. The CMS waiver, I think, actually hurt us in the States, because you're trying to get it done and get this waiver approved and then start within so much time. So you're kind of going live and then socializing. And that is much, I feel like I say all the time, it's the boulder up the hill. So you've got docs that think you're stealing their patients. You've got the ED that's going, I have metrics that say once admitted, they have to be in the bed upstairs in 15 minutes. What do you mean wait 2 hours to go home? So you just really have to kind of figure out where to embed yourself in the process that doesn't make people feel threatened, still makes, everybody happy. And the metrics, once they're accepted into the program, don't count against them. They're part of our metrics now. So it's just figuring out that balance, and every system's different.
And I think it's a little bit,
More like pull.
yeah, I would say that. I would say that. I think you have to be aggressive in your recruitment. And whether you have 1 week to do that or 6 months, you can do it. When I set up my London program, I had a 2-hour train journey in and out of London. I was there from 7 o'clock in the morning to 11 o'clock at night. I often got the last train home. And so, you have to be there if you want the program to succeed. And that's what I said about recruiting those leaders. And I think your leaders do have to be clinicians a lot of the time, because if you're speaking the speak, people will believe you more and trust you more if you're speaking their language. So I think aggressively recruiting patients and getting your team to get alongside people and winning them over, because it's just finding those. You only need one person in the emergency room to believe that you're on their side and that you're going to help them. And that person will tell everybody else. So, this is about interpersonal relationships and finding that key person that gets on with everybody. Whether it's administrator or nurse, that, somebody that is able to communicate well with people and win people over, and, to just launch the program. I think it's really, really important.
Thank you.
And after you pull them, just remember to circle back and give them outcomes.
Yeah.
Because that's the other thing is everybody starts remembering when you go, remember that Mr. Joe that was down in the ED and, you weren't sure about coming to the program. This is what he did. So we're making it to kind of close the loop, is to go back and tell people, this is what happened. This is how he did. And, then people, not only that, it also puts a face to it. So that's helped a lot. And then you have them start to push you people.
Sorry, did you have a question? Yeah. Mm-hmm. That's up to however your program is. Honestly, 3 to 5 days is the average, but how many patients outstay their DRG? It's a 5-day DRG and they're in there 10 days. So this patient first, if the patient needs 6 days, then I feel you should give them 6 days. But that's my belief. And that's what I will be telling anybody who sets up a program, that's what you need to do. But that's a personal belief.
And remember, Bonnie, for the waiver, as long as they meet inpatient criteria,
Yeah.
they can stay.
Yeah.
We had somebody in 21 days, but he kept having issues. So he kept meeting inpatient interqual criteria,
Yeah.
so we could keep him.
Yeah. Mhm. I think that's part of the DRG. If that patient had gone into heart block when they were in hospital, that would have been all covered. So it still has to stay under that umbrella. It's a different, if he went into heart block, that would be a different hospital DRG. So therefore it would be a different DRG within that stay on hospital at home. Because you have to, and I think if you keep in your head, this patient would otherwise be in a hospital bed. What would happen if he was in a hospital bed? That really should help you work that kind of stuff out. Sorry, I'm not repeating the questions for the online
know
people.
that.
Sorry. I'm sorry, the online people, that I'm not repeating the questions. Anybody else got another question? Okay, I'm just going to tell you a little bit about the oncology hospital at home, because again, this is a great pathway for patients, hospital at home. Uh-oh, what's going on here? There. So we've published 2 papers in the New English Journal of Medicine and the Journal of Oncology just about our outcomes. And then we won an Innovators Award this year. So we were first place. We beat Mount Sinai, so I was quite happy. So that's just a little bit. So the links of those papers should be on here. So with the oncology hospital at home, I just want to talk about those published papers and the outcomes that we published, which kind of give the program a little bit of a national, give it a national sort of light up. So I'm just going to talk about the background, why we decided to do it, the study design, the program description, and then conclusion. So we know that cancer patients often have unplanned hospitalization and utilization of emergency rooms. So although most of their treatment is done as an outpatient, there's a big gap between what happens in their clinic appointments and in their hospital appointments, and then they're just kind of put out to pasture to get on with it themselves. And actually, we know that the side effects of symptoms, the progression of disease gives these patients huge things to try and manage all on their own. So we wanted to look at, if we provided that acute level at home, would we help to decrease unplanned hospitalizations and emergency? So the program was to provide hospital level care to these patients that would otherwise be in hospital. And we wanted it obviously to be expert and professionally led. It was 24/7 cover, short-term provision. We did take step up and step down referrals. Step up, I mean, from the community, and step down from the hospital. This was a demonstration. So we had $3 million for 3 years to prove that if we looked after these patients, we could help the hospital and also better outcomes for the patients, to help them with their bed capacity. So So as I said, we wanted to improve the patient and family outcomes. The symptoms of cancer-related things are very complicated, and the treatment, it causes interference with their treatment, their quality of life, and really we want to look at those complications that occur in the home. How can we help those patients and family to look after them? So we did our scoping. I went into every medical record, 4,000 of them, to see why were these patients coming to the hospital, and therefore what would we expect as a hospital at home program. Excuse me, let me just have a drink. And the most common reason they were presenting was for poorly controlled symptoms. And 40% of those presentations ended up on a hospital admission with an average length of stay of 9.8 days. So yes, very complicated, clearly. So we wanted to see if we could reduce those unplanned. As I said, that of those that were presenting with poorly controlled symptoms, 13% of those hospitalizations were within 30 days of discharge. 42% of the readmissions were people that were just coming in and out all the time. So clearly they were coming in, they were sorting that presenting problem, but then they didn't sort it in a long-term way. So the patients were just representing. So we were really looking at how do we reduce the costs, help the patient, and help the health system. So we did a prospective comparison. We didn't do a random controlled trial because we knew that this was going to fit patients, and it wouldn't be fair to take some patients onto the program that we knew we were going to help and leave others. So what we did was, this is the bowl, I call it, of Salt Lake. So we had patients within 20 miles that came onto the program. Anybody outside of that should have been onto the program but lived outside, they would come onto the program. So they met the same criteria. They had come in as an inpatient, and if hospital Huntsman at Home had been in their area, they would have been referred to that program. And really what we were looking for was health utilization. The primary outcomes were health utilization, readmissions, emergency department, and costs. So we did a 30-day prior enrollment, and we propensity scored it, which basically just means we're trying to compare apples to apples. We looked at their healthcare during the 30 days following enrollment, and we did we did a comparison, patient-wise bootstrap. We looked at their length of stay as well and their ICU stay. So this was really, the demographics were pretty similar in the control group to the other group. I think that we had more women in ours than the other, but the rest of them, you can see metastatic disease was one of the highest presenters, and that's obviously because they've got the most complex symptoms. So a lot of the patients were on reversible treatment. Some of them were like, on their 9th or 10th line of treatment, and it's just like, yeah, this isn't heading how you want it to go. So we kind of looked at length of stay and things like that. I'll just scroll through this a little bit and just give you the outcomes were that, the patients that were on the program, we reduced their unplanned readmissions by 57%, which is pretty decent outcomes. I reduced the length of stay to 1.19 days, reduced their presenting to the emergency room by 48%, and reduced costs by 47%. So all in all, the patients that came onto the program had far better outcomes, and I would say personally probably felt better because they were able to be at home. And these patients, something that we did, which I can talk about later, was that this was the only program that I allowed patients to self-refer once they'd been on the program, because what I felt was that, what happens if you are having 3 weeks worth of chemotherapy and then you start another, a month down the line, you start it again. Well, you're going to have those. Why wait for that person to be on their knees, with their head in a bucket before you do something? So we just said, if you start your chemotherapy, give us a call and we'll be out there and we can sort of give you your fluids and your antiemetics. So it won't work for every program, but it worked really, really well for this. So we had our inclusion criteria within 20 miles, you know, that they had to be presenting to the emergency room. We had an acute care clinic that we took them from, but of course, on the waiver, you wouldn't be able to do that. And a lot of it was for rehydration, IV antibiotics. And, you know, exclusion criteria is no brainer for these. You know, they're too unstable. They need 24-hour care. They can't mobilize if they're on their own. And then that they can't engage with the program due to mental health issues or whatever. So, you know, really that matches most. So the program, we had a program director, that was me. We had a medical director, 9 nurse practitioners, administrative reports. We had an operations manager, and then the home health provided RNs, home health aides, and PT, OT. And so this was kind of what we, you know, for me, you were talking about, you know, building the program and what the capacity is. I would say in an 8-hour shift, they should be able to do 3 to 5 visits a day, and a 10-hour shift, 4 to 6, 12-hour shift, 6 to 8. But then I know I'm a slave driver because I feel they should be able to do that. It's not that they, but also you have to build into that a little bit of resilience for a sick patient. And something that I did when we were interviewing was, you know, an interview question would be, oh, you know, you've been given your list of 8 patients and you get a phone call to say, could I visit somebody else because they're stuck with a patient who's very sick? What would you do? You know, and if they'd say, well, I'd leave it, then you knew that this probably wasn't for them. So, you know, because you want people to be able to say, well, how do I multitask? How do I look at prioritize my patient list and see who needs a visit, who doesn't need a visit. So the daily operations, you know, to try and be as effective and as efficient as possible. We had that clinical hub. We had the cars were ready to go, as I said, with the EKG, bladder scan, IV kits, first doses, all there. And, you know, I would say anybody starting a program, never be afraid to, you're not going to design it day one and get it right. All of my programs, I've had to evolve it and think, well, that's not working. And we're like within week 2, think we've got to change that. And don't be afraid of change because it's here to stay. And certainly with this program, you just have to go with it. So, you know, our clinical staff, the phones were always answered. They took the referrals, they scheduled the appointments, they did all the labs. So we had an admin staff that did all of that. And then, you know, the clinical staff, they had hotspots because, you know, a lot of these areas didn't have internet. So they had, to get the connectivity, they had their PCs out there, they had their phones, the HIPAA compliant app. The home health used this thing called Matters Most, which is just like a chat room, but that's where we did all our sort of talking, our everyday stuff. We had every morning we had like a mini ward round where the home health would call in, the nurse practitioner would say, you know, I want you to do X, Y, and Z, so that everybody knew what was expected of them and why they were going to see the patient. And then, you know, it's really important that there's that the team feels like, because we were the home health and we were acute staff, it was really important that the home health staff felt that they could always call and always ask and not have somebody say, why are you asking me that stupid question, kind of thing. So again, it's just about that and about having that, you know, negotiation with staff. And then the remote patient monitoring and the dashboard, that is in the central hub, but the nurses all have it on their phone as well. And, you know, that was a really important. And after 8 o'clock, our phones transferred to the home health, and then the home health. The medical director of the home health, all a little bit incestuous, was also the medical director of our program. So she could then answer the phone if they needed it answered. So we had cover 24/7. This was the remote patient monitoring that we looked at, that we used. You know, we customized it for the patient. And, you know, I did like the fact that it detected, you know, their falls and things like that. But what I learned was, if somebody assists them to walk, it doesn't detect that assisted walk. So just one of these things. So the referral pathway was very, very easy. Actually, on Epic, people just put a referral in and we were able to pick it up. But also we did it via the phone. This duty clinician would accept or decline the patient, depending, she would have that conversation with the referrer. Because we were part of the oncology, we were part of the Huntsman, the oncologist very, very quickly bought into this. And so that was one of the reasons why in the start, we thought we needed like the medical director to be there with the patients, but the oncologists just wanted to keep us in touch with the patient. So, because it's their patient, so they're a little precious over it, which I loved, because they would, if one of the nurses was out in the house and something was wrong with the patient, they could text the oncologist within 5 minutes. It was like, do X, Y, and Z, or else bring them up to clinic, Z, and bring them up to clinic. So they would make space in their clinics and things like that. So that, again, that would just, because sometimes if somebody was having really bad symptoms with cancer, it could be that it's just treatment. It's something that is happening in their treatment is causing, but it could also be a disease advancement. So you can't ignore if with this more than other conditions, you can't ignore what's presenting to you. So you really have to do that differential diagnosis, and the oncologist really helped with that. And so we planned, so the RNs did 2 visits away a day, and RNPs visited every day for 5 to 7 days. That was when we started the program. Of course, COVID then hit, and they were doing a lot of that remotely. But the main reasons for referral were pain crisis, dehydration, failure to thrive, very, very prevalent in cancer patients. I think everybody underestimates the devastation that cancer treatment can do to people. And these people, their weight was dropping, they had no energy. Nobody was really giving them that nutritional advice and things like that. So so we would just have to coach them through. We would get them a dietitian. We would get them physical therapy. We'd just try and help them get on their way again. Nausea, vomiting, hypoxia, surgical discharge. We took HIPEC patients, and HIPEC is pretty complicated surgery. And we used to take them early. Anybody that came to Salt Lake, I think we covered 5 states. So if they came for their HIPEC, they had to stay in a local place, and we would look after them until they were signed off. So, and those guys are sick after that surgery. I don't know if you know what it is, but it's a big surgery. And then, our interventions were pain medication titration, electrolyte, we tried to get their electrolytes right, infectious management, fevers, IV antibiotics, nausea, deconditioning. And as I said, I've already told you these results, so I won't bore you with them, but they were good results and good outcomes. And the patient, it was recognized that during their journey, whether it's curative or palliative, they will require some acute management for their disease and their comorbidities as well. So what next? We did start, there's lots of health disparities in rural Utah. 96% of it is a rural frontier. So we chose Moab and Price. Moab is about 5 hours away from the hospital, 10 hours round trip. Price is about 3. So these patients had a big journey. One, they were a poor, they weren't a very wealthy town. If you live in these mining towns, there's not a lot of money around. Moab is a transient population because it's a tourist place. So nothing to do in the winter for these people, no work, and then the summer, they're busy. So these people didn't have money for gas, for food, I would say when we first started, it might be even as much as 50 to 60%. We had to go to food banks. These people had no food. We were buying ensures and things ourselves, and then we managed to get some funding for that. But so very neglected community, but boy, did we make a difference very, very quickly with these people. We were bringing that acute care to the home. We started the program, about 6 months ago, and we've seen 57 patients and prevented many, many escalations. Thankfully, you know, what we did was we got involved with the local little hospital. So even they weren't our hospital, but it's just you know, again, I went and spent time with these guys and said, we're not trying to steal your business. We want to work with you. We would rather escalate these patients to your emergency room than have them go 5 hours away. How can we do this? How can we work? So one of my RNs goes to their discharge meeting and things like that now. So we had that, you know, because again, it's not about silo working. And when you go out into these rural communities, you just have to be part of that community. You can't come in as the big I am and take over. You have to say, how can we work with everybody, you know, to look after these patients? So this is it. This is me. This is all the groups. So you've got the users group. That's the American Hospital at Home Users Group. The World Hospital at Home Congress, which I've spoken at twice. It's only gone twice. And then I'm part of the UK. But I would look at all of these because all of these will give you different stuff, because you want to hear what other countries are doing to give you ideas. I know you're stuck with your waiver, but you know, there's no limit to what you can do, you know, and to drive that care back into the community like it was in the 1930s. And that's my email and my Twitter if you're interested. So questions? Is there any questions on there, that chat? What's that?
Yeah, I was going to say there was one from earlier. Hold on one second. Let me get it for you. It was about the monitoring in the home. So this is Larry's question was, can you share what the remote patient monitoring expectations would be, or what you've seen in other programs? The vital sign expectations, how many times a day transmission was required? Was it continuous or episodic?
So we use continuous, but we let the patients know from 8 o'clock at night to 8 o'clock in the morning. It wouldn't be, and that was a legal thing because we didn't want them having an MI in the middle of the night. And it was monitoring their heart. So we just basically said from 8 p.m. to 8 a.m. And we got them to sign something to say that they knew that it wasn't going to be monitored. But definitely in the remote, I mean, if you think of it, you know, these nurses, the home health nurses were in a base in Price, but they could have a 2-hour round trip for one patient. So if we could reduce one visit a day by that remote monitoring and just have a telehealth call, it's, you know, really it just made so much sense. So I think the more smarter that remote monitoring gets, you know, these especially in your country with patients are so remote and vulnerable. I think it'll be utilized. We didn't use it as our eyes and ears. We just used it as a foundation for information. So we would still call in with the patient, but at least we would have alerts if something was going on. Anybody else? Any other questions? No? We're good?
All right. Well, thanks everybody. Again, for anybody who was taking this for CMEs, make sure you come. And whoops.
I know. Sorry.
No, you're good. And if you go onto the event app at the very, very bottom is the deck that Karen used. So everybody has access to that. And there's an evaluation form. If you guys could complete that, that would be great too. So thank you. Appreciate you guys coming and hanging out on a Sunday.